I started at I want to say 430 pounds probably. In the first month, I lost 60 pounds, which was crazy. But then I went down to 200 pounds and then I started climbing, and then I was doing triathlons and all of it. I hurt myself, but then I started seeing Dr. Cooper because I was like, I'm doing everything I can to not gain this weight back. What am I doing? What is my problem?
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's good to see you two.
Nice to see you.
All right, on the show this week, we're talking about bariatric surgery, a cautionary tale. One of Dr. Cooper's patients, Rebecca, is going to join us in just a few minutes. But I thought we should probably first set the table, Dr. Cooper. I have no idea what bariatric surgery is, what it looks like, what it does. Can you give us sort of the cliff notes?
Sure. Bariatric surgery is surgery that's used to assist with weight loss in people with obesity. And in some countries, it's actually the same procedures are done to prevent diabetes too, or treat diabetes. But there are two main types of surgery that are popular. One is a restrictive surgery where part of the stomach is removed in order to create a smaller size stomach that accentuates stretch receptors in the stomach, and that helps balance a lot of our metabolic hormones. The other type of surgery is a malabsorptive type of procedure where there's some kind of a restrictive procedure. It could be taking part of the stomach out, or it could be pinching part of the stomach to make a little pouch out of it to reduce the size of the stomach. And then it's accompanied by a bypass, an intestinal bypass, to bypass part of the small intestine where nutrients are absorbed. So that is a mixture of restrictive and malabsorptive type of a procedure. So the restrictive alone doesn't change your absorption of nutrients. And then the malabsorptive type of procedure bypasses part of the intestine, which does limit your absorption of many key nutrients.
And just so that I understand it, Dr. Cooper, so these surgeries do two things. They keep you from absorbing energy in the stomach, but they also have an impact on the hormones that the stomach creates. Is that a fair statement?
Yes, it really is. And so the purely restrictive procedure, often the most popular is the VSG, vertical sleeve gastroplasty or gastrectomy. So there are two ways of doing it. One is endoscopic, where they actually create a seam in the stomach internally in order to make the stomach chamber smaller. And that could be actually reversed at any point too. They do it through an endoscope. So that's not a full open surgical type procedure. The other would be a laparoscopic procedure where they go from the outside of the stomach and they cut that lower part of the stomach out. And what's interesting is that lower curvature of the stomach is where ghrelin is produced. Most of the ghrelin that our body produces is produced by that part of the stomach. So that procedure kind of resets the ghrelin levels pretty long term. But if they do it through the endoscope, it's not known whether it does long-term inhibit the ghrelin because that tissue is still sitting there. The just purely restricting the size of the stomach and increasing those stretch receptors enhances the function of other gut hormones like GLP-1 and GIP, which are similar to the medications that are used in obesity treatment, our own natural ones are enhanced by that restricting the size of the stomach. And so then when you add to it the malabsorptive portion, it does, if you don't remove part of the stomach where the ghrelin's produced, it's not going to have a long-term impact on ghrelin. There will be a short-term improvement in ghrelin, but then that reverses over time. But the other changes in the hormones are similar, whether you do the malabsorptive procedure or just purely the restrictive. So, but these things work initially. I mean, even within 4 days, the hormones have changed. And things like insulin resistance can reverse within 4 days of the surgery. So when we used to think, or doctors used to think, that the surgery worked by limiting people's food intake, they've come to realize that's really not the core key mechanism of how the surgery actually works to regulate the body weight, that it works much more on these hormones that regulate our metabolism. And that process starts within 4 days of the surgery.
Wow.
So it's pretty fascinating.
And refresh us on the role of ghrelin, if you would, for folks who aren't familiar.
Yeah, ghrelin is, as I say, the majority of it's produced in the lower curvature of the stomach. And it's nicknamed the hunger hormone, although it doesn't always make people feel hungry, but it sends a signal throughout the body that your body's too hungry. And that hormone then goes through our circulation and our nervous system to inform our brain that our body's too hungry, And then that could cause a lot of blockages in our brain metabolic pathway. The brain pathway is termed the melanocortin pathway, which is key for weight, appetite, and blood sugar regulation. So ghrelin, even though it's thought to be a short-term hormone, meaning if you go without eating for a few hours, it goes up, and then once you eat, it goes down. Scientists have thought it wouldn't be a big player in metabolism. But what can happen is over time, having repeatedly high levels, it can actually change the baseline so that your baseline level is constantly elevated. And when you eat, it doesn't really go down very much. And this is particularly true in people that have high body weight or who are chronic dieters. So ghrelin is a big player. It's bigger than we think. And it also is one of the key hormones that blocks the positive signals that come from the body fat, such as leptin. Leptin is another beneficial hormone that tries to signal that we're not in any kind of a food shortage. And ghrelin, if it's circulating at a high level, it actually blocks the receptors in the brain, so they can't actually see the leptin very well. So it's important. So removing it can have a really good effect long term.
Hi. How you doing, Rebecca?
I'm good.
I am a fellow surgical patient. I had is it called the VSG? That's what I had, Dr. Cooper?
Yep, that's what you had.
And we thought that if after I had the VSG that all would be wonderful. Not so much. I mean, it was definitely, I'm happy that I had the surgery. I'm happy that I did it. And some of it, I would say it was successful on some levels. And on other levels, for me, we thought that I could go off a lot of the medications that I was on. Not so much. But I know that you had other issues that were not so good. So maybe we should discuss them.
Yes, I had a interesting surgery that I don't know if many people had. I, at the time, decided to do some research about what the most, I guess, at the time, thought that I wanted to make sure that I couldn't out-eat my surgery. And so I really wanted to make sure that I wouldn't gain my weight back. So I did a bunch of research and I went down to Oregon to do a surgery that most people weren't doing at the time, which was considered more drastic at the time, which is called the biliopancreatic diversion duodenal switch. And that's where they not only make your stomach smaller, but they also make you malabsorb. And so they take your common channel of your It's either your large intestine or your small intestine. Dr. Cooper knows one of those. And they make it so you don't absorb some of what you eat, depending on how much of that they take.
You had a really extreme, and it was way back. When was it? 2004?
It was, yeah, it's 20 years ago.
20 years ago.
Yeah.
And it was a pretty extreme. They actually still do that procedure. And it's thought to be like the most effective.
That's what they told me. They said, oh, yeah, this is going to really solve your problems.
But the interesting thing is, while Andrea, your VSG procedure, you couldn't go off of some of the metabolic meds, but we were at a point where they weren't even working well enough to make progress, and it enabled progress, even though you couldn't. Yeah.
I'm happy with mine. I'm happy with it.
And as you said, you can absorb your nutrients, which is great.
Oh my God. Yes.
But then Rebecca came first to see me, and your weight was going up, and you weren't even eating hardly anything in the beginning.
I started at I want to say 430 pounds probably. In the first month, I lost 60 pounds, which was crazy. But then I went down to 200 pounds, and then I started climbing. And then I was doing triathlons and all of it. I hurt myself. But then I started seeing Dr. Cooper because I was like, I'm doing everything I can to not gain this weight back. What am I doing? What is my problem? And I actually went to see her after I went to eating disorder treatment because I thought, I'm so bad that I'm out eating my surgery. I must be a horrible person. So I went away for 6 weeks, and then they were like, no, this is not you. Something is wrong. Why don't you go see a doctor? And I was like, really? Wow. Maybe this is not just me. So then I went to see Dr. Cooper out of desperation. And, she was kind of a little bit of my saving grace, thinking that I wasn't a horrible person after all.
Well, and you were under eating, if anything. And you had this extreme, it's called hyperinsulinemic hypoglycemia. And it's similar to what you have, Mark. Same thing, but so extreme.
So this is super low blood sugar?
Yeah, it was. And the insulin just skyrocketing after eating and then crashing the blood sugar. And it wasn't that the blood sugar was rising, that most people think it's your blood sugar. It's not. It was an abnormal insulin spike. And that was probably the original problem too. And they find that with surgery, it sometimes gets a lot worse after surgery. And then that causes the original problem that caused the weight to just still be there. And so you were actually gaining weight. We were having a hard time getting the weight to stop going up. It was really going up, and it was past, I don't like to say numbers, but just so people realize it was past 300 pounds. Like you'd had that crazy surgery that's supposed to be like reversing obesity, and now you're gaining weight rapidly, and it's just surpassing one numbers after another, and we're trying to throw everything at you medication wise. And
but the worst part of it is that I was really low in iron. I was really low in all of my vitamins. And so I was super tired and super exhausted. And yet I would go to the doctors and they would say, but you're absorbing food, so obviously you don't have a problem. And I would be like, so I was just stuck in this really awful place of, and nobody could tell me how many vitamins to take and how much I was actually really absorbing because, I was just in this horrible place. And so, just more recently, it's been a little bit of adventure. I went to a surgeon to see about trying to absorb vitamins. And they put in a feeding tube just for vitamins. And that was 6 months of agony, which I really honestly couldn't move because the feeding tube was a little bit infected. Anyway, I gained I don't know, a tiny, tiny little bit. That's it. And so when I went to the surgeon, I mean, he was great, nothing against him, but he said, because of your weight, it's still high, because of your weight, if we were to reverse this, you would basically be in this really unique position. We would probably be writing a paper on you because when I had my surgery, it was a completely open surgery. So there was scar tissue there and that kind of thing. So you would be probably a Mayo Clinic case. We would do a paper on you. And, I have a child and a family, and that's very scary for them to know that, just to reverse this so that I can absorb vitamins and nutrients that I would be such a unique case at that point that I would have to go under something that would be, really pretty
Dangerous.
scary and unique and make me unique. I don't want to be one of those patients that are like, oh, I've never seen like this before. I want to be the patient that I'd like, I've seen 100 of these before, because nobody wants to be that weird patient.
Right.
And Dr. Cooper, explain why the surgery didn't work.
Well, yeah. And so that's the problem. Is it's such a good question because bariatric surgery is such a fantastic tool in the right case and the right type of surgery for the right patient. And as an adjunct to the medical treatment approach or pharmacologic approach, it can be for certain patients really good. But there's always that risk with the ones that are all bariatric surgery tends to have, these results you see in the first few years, and then you start seeing a leveling off and some weight regain. The vast majority of people don't get back to their starting weight, but it's still very disappointing to people to see that they had this procedure and now they're still in like severe obesity ranges. But a lot of it's just because, as I said, some of the hormone changes are not sustained. They're just sort of a temporary shift, and it may improve the baselines, but not as much as it did in that first window of time, the first few years. And we just need to also, it's not necessarily reversing the original problem. Just like in Rebecca's case, the original problem was this extreme hyperinsulinemic hypoglycemia. And so it doesn't reverse that. So that's why it's good to get a full medical workup to figure out what's wrong before going to surgery so that you can anticipate what's going to happen after and bring in proper medication after. But in Rebecca's case, the biggest concern we had was, I remember you telling me how you're I hope you don't mind me saying this, but you said, I was fat, but I was happy.
I was happy
before the surgery.
Person.
Yeah. And now she said, and now I just feel terrible, because she couldn't absorb the nutrition. And so everything, as you said, Rebecca, that's where the fat-soluble vitamins, the small intestines, where those fat-soluble vitamins are absorbed and where a lot of our gut flora that helps us like make our own B12, like all these different vitamins, that's where it's all the activity is. And so iron is absorbed there too. So everything is just low. So minerals and fat-soluble vitamins. And so it just makes you feel unhealthy, and even protein levels and things like that. And so that was our biggest concern, as you said, Rebecca. That was our biggest concern, was the malnourishment. And that's why we kind of tried to explore whether the surgery could be reversed, knowing that there'd be some attitude that because your weight was high, people would say, well, you don't need to have it reversed. But in your case, the type of surgery you had was actually like a combination of the type Andrea had plus the malabsorptive. So what we were hoping is it could be reconnected so it would be just like what Andrea had. Then that would have been great. And we had the medications to help from there. But it was too tricky. That's why you went through a lot of evaluation, and it was too tricky. I think even the feeding tube was tricky to put in because of scar tissue. And that was a trial they did to just see if they could get the nutrients up, but no surgeon was really comfortable getting in there with all the adhesions. And then we worked with a dietitian who really tried to help. And it really became, Rebecca, you became sort of more of the expert on how to get your nutrient levels up. And these high dose things you had to do with injections. Yeah. But I will say that one good thing is that finally with the newer medications, like the older medications that we've had for the last 15 years, 20 years, have not been powerful enough to reverse the metabolic dysfunction for you. And so even your body weight has just increased. Your blood sugar regulation's still been rough, But luckily, we kind of, with the new medication, the most recent medication that's come out, we're having better luck.
Yeah.
So
Finally.
we're finally actually, if you wait around long enough, they'll make a medication that works for you.
Yes.
So we're happy about that. But the nutritional thing is just hard. And that's what I always try to just tell people. And I get a lot of pushback from doctors, like surgeons sometimes, who always advocate for these really aggressive bariatric procedures because they supposedly work better for diabetes reversal or for weight loss. But if you look at the differences, even if it's an X% better in the first few years, if you actually compare them, the risks are so much greater. Why would you want to take that risk for a 1 or 2% improvement over something that has so much less risk and less long-term risk? And especially when we have more modern medication now that can also come in and add it on treatment. So that's what I try to remind people, is anyone going into surgery to really question whether the alteration of absorption is necessary, because most of these surgeons, if you look at the reports, the published research, they'll say, oh, it doesn't have problems with long-term absorption. Really, it impairs it, but not enough to cause any concern long-term. But then you have patients like Rebecca, and I have other patients that had just a plain gastric bypass or some other lesser type of malabsorptive procedure, and they have problems too. Not every patient. So you'll see a lot of patients where they're fine, and then you'll see some patients are really struggling. So how do you know which patient you'll be in that mix? And so it's something to think about.
And I always thought I was going to be the patient that would be like, great, because I was healthy as a horse. And I was like, it'll never happen to me.
Mm-hmm.
But also 20 years ago, the promise that they were telling you and the drugs that were existing then,
Yeah.
I mean, I could see where that would be very, very attractive.
Yes.
Mm-hmm. Definitely.
So we're calling this a cautionary tale, Dr. Cooper. For those listeners out there who might be considering surgery, I'd love to know what your advice would be. Before they have surgery, do this.
Well, first off, find out what the problem is and have that as stabilized as possible. And then if you're not getting enough results with the pharmacologic treatments that are available now, then talk to your doctor about, do you think I might need to take the next step? I always think that there are key reasons why people would need to think about pursuing bariatric surgery. One is intolerance to the pharmacology that's recommended. A lot of people can't tolerate it, or inaccessible. Some people, their insurance will not cover it, and it will cover surgery, which is so crazy.
It's crazy.
And the other would be progressing diabetes, because if on insulin and things like that, where it's just really progressing and your health is at risk and you don't have time for 2 or 3 years of pharmacology to get to where you want to be. So those are the patients that we might say, hey, let's think about doing a combined treatment. The bariatric procedure, knowing that it's not going to be enough on its own, but it will be like taking a huge dose of powerful medication all at once to get us to a better place where it's within reach of the pharmacology that we have access to. So if we're considering that, I always recommend against the type of procedures that affect your absorption of nutrients, because as we know, nutrients help keep our metabolism strong and our health. So if it's possible to avoid that altogether, that's my preference with my patients. And then a lot of times they'll go to the surgeon who will tell them, well, you'll have 2% greater results if you do the combined with this malabsorptive procedure. And nowadays they have like a sort of a markedly toned down version of what Rebecca had that's becoming popular again. And it's a much smaller diversion and much smaller bypass. But still, I'm really thinking, do we really need that when we have really good data for the majority of patients can get away with a procedure that's just purely restrictive and you don't need to do the bypass? And if you did, you could always add it later, but you don't really need that normally in combination with the medications we have available today. So finding out the diagnosis before you go in, having a good reason of why you think you need to do that, then what procedure do you really need to do, one that affects your potential future absorption of nutrients? And picking the lesser approach is often much better because lower risks during the surgery, lower post-op risks, lower long-term risks. And the hardest thing is that there's not a solution, because someone like Rebecca, there's no solution. When you have these low nutrient levels, as you said, Rebecca, no one knows how to get those levels back up. And without reversing the bypass, how are you going to get the levels up? So massive injections of vitamins and big doses of minerals, IV. How many IV iron infusions have you had?
Every 3 months.
Yes. And it's a big commitment to just keeping your levels up. So,
well, and if I had to do it over again, I mean, obviously I'm older, so they didn't have the options. They do now, but
yes,
they knew. I took a weird blood test when I was in 3rd grade because I started dieting when I was in 3rd grade, and they knew that there was something different with my blood that made me have a blood sugar issue. I'm not totally sure because it was a long time ago, obviously, what exactly they found, but they told me that when I would eat sugar, I would always want more. And so I remembered them saying that when I was really young. So I knew back then that there was something different about my metabolism, but we just never dialed into that. And so I really wish that I had found somebody like Dr. Cooper before I had gone to that extreme, because then I might have not had to do that.
But as Andrea said, that was a long time ago, and the options were more limited. Yeah. And there was the VSG procedure, but there wasn't as much data yet. And the medications, we did have some medications, but knowing how your body reacts, like that probably wouldn't have helped that much. So you can't fault you for making the decision you did, but now we just have to figure out how to make it work for you.
And how to fix it. Have they told you that there's a way to do some sort of surgery that wouldn't be as extreme as what they said at the Mayo Clinic? Something that could help?
I mean, I haven't gone to the Mayo Clinic to have them look at me. After 2 surgeons around here, I kind of gave up at that point because I was like, I'm not sure I want to be the patient that's so unique at that point with such a unique anatomy at that point, because that would make me a very unique patient anatomy. And I'd rather have at least some anatomy that somebody's seen before, even if it's pretty rare.
You don't want to be the test.
Yeah. But I mean, I haven't ruled it out. My fear at some point is that, I'll wake up and break a hip because I don't have calcium, for no apparent reason. Because at this point, I'm only 50, but, I don't know what the future holds as far as my absorption goes. So there is that fear.
Yeah. Andrea, you started with the pharmacology, you started with the drugs, and then decided to add bariatric surgery to that mix. Knowing all that you know, are you glad that you had the surgery?
Totally happy. Totally happy, because the drugs took me to one plateau, and then having the surgery allowed the drugs to take me to the next level. And I think that was I feel like that was the right decision that Dr. Cooper and I made together. And it was a decision that we made over time. And it was also because drugs had changed. My body was reacting to everything. I don't know. Do you think I think it was the right decision. Do you?
Oh, yes, definitely. Yeah. So you could keep making progress.
Yeah.
Sometimes it is neither one for some patients, neither just the pharmacology versus just the surgery are enough, and combining them is your best bet.
Yeah.
And that's technically what you're doing now, Rebecca. You're combining the pharmacology and the past surgery that you had. There should be somebody out there, if anyone's listening, that's an expert on nutrition, on how to get these nutrient levels up in someone that's had an extreme bypass. Let us know. But we have consulted with several people, and we have consulted with surgeons who've kind of taken a look at that anatomy and been a little bit gun shy to get in there and do anything because of potential scar tissue. So it really is a risk to think about doing a procedure for that with what we know right now. But it's true, we don't know how deep of an evaluation you've had. So if things got worse, we would probably pursue a more in-depth evaluation of that anatomy and the risks, and with the top people in the country, and see if it would be beneficial to at least look into the possibility of doing a reversal type of a procedure for at least a portion of that bypass. I know it can be done, but it's just what the risk is. And yeah.
And I think right now I'm finally making progress on the
Yes.
weight side of things with Manjaro, Wegovy kind of thing. And then also I finally found some options. I finally am getting some vitamin D in. My only remaining, well, not my only one, but my main remaining issue is vitamin K. So haven't found a way to get that, but hopeful that maybe someday we will.
Yeah.
Rebecca, what is daily life like for you right now? Are you doing okay?
Yeah, I'm great. I have a child and he keeps me active. So, but yeah, no.
And you know what? You're
good.
always laughing and smiling. Always,
Yes.
since I met you.
Yes. I have a family and I want to make sure I'm healthy for them. So,
Right. So other than that, you're still healthy.
yes. Yeah.
And I think that's also another thing. It's like the weight loss was very important to us, but the health issues were really priority.
Yeah, it's funny how life changes. You know, and there was a certain time where your focus was, I just want to be thin. And now, I just want to be healthy and happy for my family. That's it's changed focus a lot now. Maybe it's wisdom of being older.
Well, I do know something, Rebecca, and that is the fact that you were willing to share your story really has allowed other people to learn from it. And, like every medical decision, a lot of times there's a lot of gray area. And the answer is it kind of depends. So, bariatric surgery is something that we just have to take a look at. And what are the existing procedures? What are the existing medications? And we consult with our docs, and then we make the best decision we can at the time. So I really appreciate your willingness to share the story. I've learned a lot today, and you seem happy. I mean, you just seem like a really happy person. So thank you for that. Andrea, any final thoughts from you?
I think that what we get out of like surgical decisions is you make the best decision you can at the time. And we all learn that things change and you do what you can. I mean, you make the most educated decision that you feel you can at what's best for you. And what's best for you might not be right for somebody else also. I've learned that over the years too. Like what you have might not be right for somebody else, but I always feel like I did the right thing for me.
Rebecca, any final thoughts from you as we part?
No. Yeah. I think Andrea is totally right. You have to make and I always think back and I'm like, I was making the best decision I was made at the time.
At the time.
Yeah. With all the data I had at that time, I might not make that same decision today, but I would have probably made it again then. So,
yeah. Dr. Cooper, what about you?
Well, I just think Rebecca's you've had the best attitude, even though you've had all of these stumbling moments and things. But I really appreciate you coming on and sharing your story, just because I think it does highlight that there is a potential side that people have to be aware of, because I think sometimes bariatric surgery and these weight loss meds, we don't like to call them that, but this new attention to this group of meds, sometimes it's promoted as if it's just a real easy thing. And you just take this medication or have this surgery and your life will change for the better. And so I think it's good to step back and just give this information so that people can make it a more thoughtful process.
Yeah.
And
Well-
it doesn't happen overnight.
No.
Well, I appreciate all of you, especially Rebecca. Thanks for coming on the show. Appreciate
Thanks.
it. All right. This has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.